Good afternoon, everyone. Welcome to today's prep webinar. Today, our prep webinar today is Individuals Who Sexually Offend, an Introduction to Assessment, Treatment, and Management. I'm Jen Sperduto, and I'm joined by my colleague, Dawn Reinhardt Wood, and we're from the Rutgers Department of Psychiatric Rehabilitation and Counseling Professions, and we are part of the SPRE team at the hospitals, the State Hospital Psychiatric Rehabilitation Initiative. And today we're joined by Dr. Doreen Stanzione to present our webinar today. So she's going to introduce herself in a few minutes, but I just want to do our little housekeeping. This is an interactive training. We encourage you to ask questions. Feel free to type in the chat box. And if you change the chat to everyone instead of hosts and panelists, that way everybody can see your question or your response, that would be great. If you just wanted to go to Dawn, Dr. Stanzione, or myself, then you can just leave it at hosts and panelists. We will be recording this webinar. We're recording right now, and a recording of this training will be available on our website. Dawn just posted that link. Thank you, Dawn. And if you are typing and you don't feel like typing anymore and you want to raise your hand and speak, then just do that, and Dawn or I will be able to unmute your microphone and you can speak instead of type. Just a quick note that, as you know, our psychiatric rehabilitation education program, or PrEP webinars, it's an online forum for a variety of topics that are relevant to the state psychiatric hospital staff. And while Rutgers and the Division of Behavioral Health Services are sponsors of the program, the PrEP webinars are peer presented, and as such, the content is independently developed by the presenter each month. So the views and opinions expressed in the program are those of the presenters and don't necessarily reflect the views or positions of any entities they present. So now that's all out of the way. Dawn and I will be manning the chat while Dr. Stanzione presents. So if you have any questions, comments, concerns, discussion stuff, feel free to post that in the chat. Just again, this is being recorded. So anything you say will be living on in infamy. And with that, I'm going to turn it over to Dr. Stanzione. She's going to introduce herself and get started with the presentation.
Hi, good afternoon. My name is Doreen Stanzione. I come to you, I am a former Rutgers GSE graduate in counseling psychology. I'm a licensed psychologist, and right now I'm the clinical director of the special treatment unit. And I initially went into this field. I went into to get my doctorate in counseling psychology, focused on developmental issues and more normative issues and resilience and those types of things. And when I was an intern at Greystone, I ended up having a peer who worked at the special treatment unit. If you're an intern at Greystone, you're familiar with Greystone, people, interns will be off site once a week. And one of my peers was here and told us, the group of us, and I had one person say, when she shared, "Oh, I work with individuals who sexually offend," and he said, "What, kind of what ring of hell is that?" So that was his joke. And then I thought, well, okay, that's interesting, and we moved on. And then as I moved forward through my internship, she talked about how she enjoyed the work, and I actually came to apply for a position here. I wasn't really sure I wanted to go into academia. I wasn't really sure that it was for me. But when I applied, I thought, I get licensed. It could be interesting. Let's try it out. I'm still here. I started in as a treatment provider. Then I provided assessment and assessment for the board. I chaired assessment, was psychology director, and now I'm the clinical director. And I found it's always interesting. It's and I've come to truly enjoy it. So that's how I came here. Right now, I'm also on the board of New Jersey ATSA, which is the New Jersey chapter of the Association for the Treatment of Prevention of Sexual Abuse. So I'm very happy to be here and to present for you. And I also want to say that there's just a trigger warning, I'll be talking about individuals who commit sex offenses. So this could be for some individuals, and I will do it in the most respectful way, but for some individuals, it can be trying, can be upsetting. And, that's understandable, and just to kind of keep an eye on that as well. And I'll be as respectful and understanding as possible. So the learning objectives, basically from this presentation, you're going to learn the differences and similarities between general good mental health treatment and sex and treatment for individuals who sexually offend. You might, just for the sake of brevity, you might find, I try to use person-centered language. So individuals who sexually offend, you might hear me sometimes say sex offenders. But for the sake of brevity, I may go back and forth. You will also learn about the Risk-Needs-Responsivity model, and that's an overarching way of conceptualizing who we treat, how we treat them. And also you'll learn some approaches to working with individuals who have sexually offended. And you can also learn some resources. I have to say, I tried to strike a balance. I have, when I talked with Jennifer yesterday, she said, oh, you've got a lot. So I'm trying to strike a balance. There's some of my PowerPoints are content laden, but I'm not going to go through each detail. It's more for, I'm hoping that you will leave this with a PowerPoint where you can say, I remember Doreen said something about this. Let me go back and check that out. So I'm going to try and keep it quite general. And I hope I strike that correct balance. And you can obviously give me feedback as well. So with that being said, thank you. I know it's 3 o'clock. You've had long and busy days, or hopefully your day was good to you. So I really, truly appreciate you spending the time here learning about this. So here are some of those slides where you can use these as a reference. If you want to find out more information about individuals who sexually offend and the treatment and those types, and assessment and those types of things, there's one major organization, ATSA, and that's the national organization. Here's the link here. And New Jersey APSA is your local chapter. And they have trainings probably 9 months out of the year on Fridays. So those are very good resources. And then if you want to learn more about risk assessment, there's an individual in the field, Andrew Brankley, who I find, if you just go to YouTube, he's very personable and he makes risk assessment so digestible. So if you want to, I'm not going to show him here, but I think it's if you're interested more in that, he's a really good resource. Okay. So what I want you to do is take a moment, and I want you to think about yourself, and I want you to think about a habit, either something that maybe you wanted to improve on yourself. Some examples might be, I want to exercise more, or I'd like to eat better. So think about that, whatever that would be for you, and something that you wanted to add to your life to make it better. And you can, if you want to share in the chat, you're welcome. It's really up to you. And then I want you to think about the things that have worked for you. So when you've wanted to eat better, what are some of the things that were helpful to you? When you shared with other people, were there things that they did that helped you? Were there things that they did that maybe made it harder for you, or maybe you kind of went the other direction? And I want you to think about how long you've tried to improve whatever it was that you wanted to improve. Okay. Then I want you to think about something that maybe is a little bit harder about yourself that you wanted to improve. I have a little temper, so sometimes I would like to improve my temper. My husband jokes about my temper. I hope it's not too much, but it's something that I, feel a little bit, sometimes uncomfortable about. But I have a little temper. But think about something like that you might not feel great disclosing, or you might not feel, might feel a little bit uncomfortable. And think about when you tried to work on that, what's worked, what hasn't, how people impacted you with that. And then think about something maybe that's even more embarrassing, more uncomfortable. maybe something you're even ashamed that happened, right? So think about how that might be difficult, or think about when you wanted to improve that, what's worked for you, what hasn't. And what I'd like you to do is, as we go through these slides, and I'm going to kind of refer back to some of the things I've asked you to think about in the beginning as we go through, but think about that. And as we talk about individuals who sexually offended, they have, oh, I should also say, something I wanted to also highlight is, as I talk about, I've been working with this population for a long time. Because of that, I understand a lot of what has led people to do those things. I don't have all the answers, but I understand. And with that understanding, I think we can learn to treat people, and we do treat people, and we do help them so that they don't do it again. But I also want people to understand that that doesn't mean that I'm thinking anything that anyone has done when they've sexually offended is okay. It's not okay. Understanding what leads them to do what they do is important so that we can make everybody safer. So I just want to also keep that umbrella in mind, that I'm not condoning the behavior. So, okay. So let's keep these things in mind as we go through, and then I'll come back and forth. And what I also want to highlight is some of the things that we just thought about that we might feel a little embarrassed about. Individuals who've committed sexual offenses, that may be one thing of many things that they've done, and it's impacted people's lives in significant ways. But when we ask them to do treatment, we ask them to do that often in a group format, and just kind of think about some of the how it might feel to share those things that might feel so uncomfortable in that environment. So as we go through, that might also help you to understand a little bit about how this works. So what I want you to think about, and this is something I think would be helpful for you to put in the chat, but think about in your mind what makes working with individuals who sexually offend different. Like, what's so different about this work? Okay.
While we're waiting for some responses to come in, somebody had mentioned, and they just put it to the host and panelists, so I won't say a name in case they didn't want that out there.
Sure.
She said, I'm looking to hike more since my knee replacement. I've received a lot of encouragement from family and friends, which has been invigorating. I also have a bit of a temper and would like to keep reminding myself to take a step back when I start to feel like I'm getting revved up. That's been helpful.
That's a very good example. So taking a moment, taking a pause, knowing when, your temper is more likely to come out. Those are all things that will help you to reduce your temper. And I'll kind of, spoiler alert, those are some of the things that when we're working with individuals who have offended, we help them understand what led them to do what they did. And that may be helpful. So thank you so much for sharing.
Yeah. And so some of the responses to this question, what makes working with individuals who sexually offend different? One response was it's hurtful to others. And someone else said the great degree of prejudice against this population that the general community has can make it difficult working with them. And in comments, behaviors towards the clinician, like those are some of the things that are coming in.
Those are really good examples. And I will say that it can be, as a field, when you a lot of times we take pride in our work, and I take pride in my work. But when you share that you work with this population, you get kind of sometimes extreme responses. So that's something that does make this work different, that sometimes you don't necessarily want to, always share with people immediately. They say, well, what do you do? I work for the state. I'm a psychologist. It doesn't mean I'm ashamed of the work. It just means, I'm not sure I want to share, have this conversation with people, because sometimes they feel quite open. Either asking you, which is fine as well, but it does impact the way that you interact with people about your work. So those are very astute. So and what I want to highlight is, I'm going to kind of go quickly, but there's a lot of differences. There's a lot of similarities between working with this population and just general treatment. So one of the things is there's legal issues. Most people don't come to you unless they've had some run in them with the law. you're going to be dealing with people with their arousal. About 30% of offenders have a paraphilia. Not everybody who offends has a paraphilia, or that's their primary orientation, or focus, I should say. For some, it's mandated. And then people have been hurt. There have been victims. So you're dealing with that as well. When I think about it sometimes, and it might look different, but especially if you're in the hospitals or in many different settings, you can run into people still with legal issues, maybe very different legal issues. You might be talking about arousal, you might not. If you think about if you're in marriage and family, that would be something that would come up. And then what's mandatory? Sometimes the kid who maybe doesn't want to do treatment and the parents put in treatment might feel mandated, that kind of thing. And sometimes we don't know. Other people can be hurt sometimes, but sometimes we're not always aware if somebody that we've worked with has hurt someone.
Dr. Stanzione, a question came in. What is paraphilia? If you could.
Oh, I'm sorry. It's paraphilia would be if you have, say, a primary arousal to pedophilia would be arousal to children, or if you have an arousal to rape, that could be a paraphilia. So it's a type of sexual arousal that is problematic that can drive you. So something I actually wanted to talk about a little bit is that some individuals who offend may do it because there's just more of a general criminal orientation, and some may do it because they have that arousal to children, to assault, those types of things. So if you're working with an individual, you kind of want to understand what drives it. And if it's driven by that arousal, that paraphilia, then you would treat them differently than if it's somebody who they have a more general criminal orientation and they take what they want when they want it. So those are different ways that you would work with people based on whether they have a paraphilia. But there's also a lot of overlap, and we've also found that there are a lot of offenders. It's not all, there's a lot of overlap, I should say. And you can have an individual with a paraphilia and who engages in just general criminal behavior. So other things that are important in sex offender treatment, and these are things you will run into as well. Rapport is really important. Rapport is the magic that helps any therapy work, and it's the same with individuals who have offended. With individuals who have offended, you want to be a little bit more cautious with boundaries, and different. We typically would have strong boundaries anyway in any type of treatment, but it's especially important with working with individuals who've offended. You also have a population that has a lot of adverse childhood experiences. So probably about I'm going to get into the numbers. I'll come back to the numbers a little bit later. I have a slide that has those specific numbers. There's a lot of trauma. The population I work with, individuals who fall under the SVP Act, the Sexually Violent Predator Act, they are considered the highest risk offenders. So they come to us after they've finished their sentences in prison, but they're still considered at high risk to sexually offend. That population seems to have an average of almost 5 ACEs, whereas in the general population, I want to say it's about 12% of people have 4 ACEs or more. And if you're familiar with the ACEs, the more ACEs you have, the more at risk you are for health consequences, for mental issues, and a whole myriad of things. So this population, some may have been offended against, but many have a significant amount of early trauma. We also look at stages of change. You need to consider whether someone's ready to change. We also work with people who need improvement in social skills. You can burn out in this field, but we also know that that's not specific to individuals who working with people who offend. You might also experience compassion fatigue and transference issues. So a lot of the same things we would work with, you would see in a myriad of other types of just general good mental health treatment. Okay. What I also want to think about, I want people to think about as we go through this is as we look at risk factors, we want to think of ways to kind of cool the risk and ways to help protect people. And that can be the work that you and I would do with them, but it can also be work from people in the community where their parole can assist, and looking to supports in the community, even if they have supportive family. So the more protective factors we use to help the individual reduce their risk, the more we would improve their ability to not reoffend. And I'm going to go quickly through this other slide. We basically we integrate theory, assessment, and treatment. So we want, and you'll start to see, I have a lot of slides, but there's a lot of them should go really hand in glove, and you'll start to see kind of themes as we go. I want to talk about what's called the Risk-Needs-Responsivity model. And what that basically means is you want to treat the level of risk that the individual poses, and that risk, that initial assessment, will help you kind of understand what to do with that individual and how to best help that person. And you want to think about, I know Goldilocks is used pretty frequently, but I guess because it's such a good way to think about things, you want there to be a good fit. So for example, if you have somebody, right, I mentioned that people could have paraphilias. If you have an individual who is driven by their arousal to children, you wouldn't necessarily go and work on treating them for as you would somebody who is more antisocial. So you kind of want to find the right fit. You want to find the right fit in the amount of treatment that you give. If I were to ask you, or to think, what's the likelihood that somebody who's committed a sexual offense will commit another one? And you can put it in the chat or you can think of it. What numbers would you come up with? Sometimes people will think that people who've offended will have 100% chance of risk of reoffending. And the actual general number is closer to 12 to 15%. So most individuals who have offended don't go and reoffend. But when we look at who we want to treat and how we want to use our services in the community and as wisely as we possibly can, we want to make sure we're treating the people who need it the most and who will benefit from it the most. So over time, this field has changed quite a bit. It used to be that everybody who's offended would get kind of, I wouldn't say the exact same treatment, but I've talked to practitioners who said, I'd have somebody who was low risk, and then we'd try to, make their risk perfect. And so we'd give them treatment and we'd shine them up and do those. And then what they found over time was that if you have somebody who doesn't really have a high risk to recidivate, and you put them in a group with other people who have higher risk or more pathology, you can actually make them worse. So you want to make sure that you have the right fit. And sometimes the right fit could be just good general mental health treatment. And for somebody who's committed more offenses and has a higher risk, it could lead to needing more kind of more of a custody treatment. And at least in New Jersey, we have the SVP Act. So you could be led to be where I am, but kind of understanding who to treat is very important. Now, I'm not going to go into, and this isn't going to be a full, understanding risk. It's going to be just a general explanation of risk assessment, but I think it's important to understand treatment. So when you think about the risk-needs-responsivity model, just think about the words. You got risk, needs, and responsivity. The risk is you want to understand the probability of somebody reoffending. And the probability isn't just the numbers. It's also, if they were to reoffend, what would they do? So if you have somebody who may expose themselves to people, they may have a higher risk of doing that, but you would treat them differently. If you have an individual who has a higher risk of committing, a sexual murder or something like that, they might have a lower number of risk amount, but the risk that we would be comfortable being out there would be less. So let me go to, and I'm actually getting ahead of myself. So you have the risk. So that's the probability with the potential victim trauma. The needs, and this is what do we treat? How do we treat it? Some people are going to need therapy, some people may not. Some people might need community supervision, some may not. And then you also want to look at responsivity. You want to deliver things in the best way that you can. So for the individual who gave the example of them, I thank you, but having a temper, well, when you think about what was helpful and the people, maybe if there were people who helped you with that, if they supported you in a way that you were ready to be supported, you probably did the best, right? If they yelled at you, it was probably a little bit harder, right? So, okay, so now I'm going back, I'm going to repeat those couple of slides. So I'm going to go back to the probability piece. I want you to think about if you were to purchase a house. If you were to purchase a house and say you wanted to know whether, you make a lot of calculations. So is the house and this is kind of relevant because we've seen a lot of flooding lately, but if you purchased a house, is it in an area that's highly flood prone? And say if you had to get insurance for that house, you would look at, is it in a flood prone area? Is it at risk of fires? What are all the risks that could happen around this house? Your insurance rate for that house, if it's a house that historically has had a lot of flooding, is going to be much higher than a house that hasn't had a lot of flooding. If it at the same time, if you have a actually go to jump to the okay, so if you have a house that's a high risk of flooding, you're going to pay more insurance. You're also going to come up with a probability of the house flooding. So say, for example, if you found that the house that you were purchasing had a 40% chance of flooding within the next, say, 50 years, would you decide to pass on it? Would you decide, well, maybe it might have this risk, but there's things that I can do to the house to protect it, so I can create, plantings and things like that, or I could, remove the gravel from my driveway so that the water can go into the earth. So you have different things that you can do to improve the risk of your house flooding. Would you do those things? You might make a calculation, and then so everybody here, when I say you have a chance of about 40% that house might flood, you're all going to take a different risk. You're all going to be okay with that in different ways. Some people will take a chance, especially if it's a good deal, and some people might think that that's not okay. I'm going to go to the next slide. Actually, I'm going to go. One of the instruments that we use to assess risk for offenders, and think back to the house, is what's called the static 99. So when you're calculating your estimate for the insurance for the house, it's going to be based on the historical factors for the house. When we're looking at offenders, when you're calculating the risk for them to sexually recidivate, you can use what's called the static 99. And I don't want to go into the real details of it, but I want to highlight it a little bit. What this does is it tells you, just like, so if you're purchasing that house, you decide, okay, I'm okay with the 40% risk. So I'm purchasing the house. I'm drawing a blank. So actually, I'm just going to jump into the static. So basically, okay, so if you're at a 40% risk of the house flooding, but that house might have the highest risk of flooding, but that may never happen. The same thing goes with the static 99. When we're looking at individuals who offend, we look at their static risk, and some individuals might have the highest risk, but they may not necessarily offend. It doesn't tell us that this person's going to offend, but it tells us that if this person has a certain score, they're going to be at risk of offending at a rate of other people who have done the same things. So let me get into the more of what would be relevant to you. So if you have a static 99, that you actually happen to have a report where you can look at that, it looks at things that generally don't change outside of your age. When we're younger, we're more risky, but it looks at the types of behaviors that people engage in that make them more likely to commit offenses again. So if they've offended against males, if they've offended against strangers, those types of things. Now, if you think back to the thermostat that I kind of showed you, the thermometer that I showed you, I had red, green, and yellow. I'm going to do this throughout the presentation. If you happen to have an individual with higher numbers, and those numbers are kind of, the numbers for the static 99 would, the range, I'm demonstrating the range right here. The higher the numbers, the more risky that individual is. And it tells you their static score of risk. So it's not necessarily a changing score of risk. It gives you kind of like the insurance of the probability that your house will flood. It's kind of the probability that this individual will reoffend. So that's what this is. So if you have this in front of you, it gives you a baseline understanding of the risk. It also tells us, we also, in addition to static risk, we also have what are known as dynamic risk factors. So those are the things that we change. Those are the things that we go in and we do therapy, because the person's risk at that moment may change. If you work with somebody who has needs more social supports, or has ideas that it's okay to offend against people, and you work with them in treatment, you can bring that risk down. So if you happen to see what's called a stable 2007, that's telling you about the dynamic risk. The other nice thing about it, and just you can come to this as a reference, is that it also tells you what you should really target in treatment. And I'll pull out an example. Okay. So one of the things it looks at is social influences. So we know that when we are with people who, so say you're trying to eat better, and you know that when you are with people who eat well, and they encourage you and they support you, you eat better, you do better. It's the same thing for individuals who have committed offenses. If they're with people who don't use drugs, they don't drink, they don't allow them to, if they offend against children, they don't allow them to babysit children, those types of things, they do better. It also looks at, and there's literally, I'm not going to walk you through the details of how to do it, but it also looks at whether you have individuals who are negative influences on you. And you literally have this kind of calculus within it. And so those would be people who maybe are introducing you to moms who have children, or they're encouraging you to drink, or that type of thing. And then you have, it also identifies whether someone's a neutral influence. So this instrument, the stable, has all these risk factors that you can see here that do increase an individual's likelihood to recidivate. But the nice thing is if you actually are able to get a hold of this, or even if you look at these different factors, you can understand what to target when you're working with somebody who has offended. So if you have somebody who has here's the next slide. So what you want to do with that, if you actually get to see the stable itself, you want to target the twos. So you want to, when there's a person scores 2, that's something that you want to make sure you put in your treatment plan and you are working on. And if you are working with somebody right now and you get a stable, or you take a training to learn how to use the stable, and you're not targeting those things, then go back, and that's what you would want to do. So whenever there's a 2, it rises to that level, that's what you treat. And that's why the risk piece of the risk needs responsivity is important. You want to know what to treat. You know, not everybody's going to, just like not everybody's going to benefit from the same influences. We're not all going to eat well for the same reasons in the same ways. You also need to make sure, same thing for individuals who offend. So, and then these are the numbers. Obviously, you can see that, you know, green, yellow, and red. And this instrument, you also, you can combine it with the static 99. So it's a nice tool to use. And if you're interested, I put the website for both of them on there. The other instrument that you might come across, and if you don't, that's okay too, because these are just things to think about, is the acute 2007. So whereas the stable that I just showed you was looking at things, that was looking at your behavior and offender's behavior within the year. The acute looks at what's happened in the past month. So if you have somebody who comes into your ER or comes to a psych hospital and they are high on these factors, that's when the red lights should go, red flags should go up, and you should be checking, you know, if they have parole, check with the parole officer, seeing what community supports they have, and you should be delving deeper and looking. They're going to need a lot more treatment. So these are things, like I said, that are happening immediately, that are more acute, that are happening within that past month. So if you have somebody who has a past history of offending against children, and they have, you know, a substance abuse history, or even if they don't have a substance abuse history, and they just lost a family, they just lost somebody, and they're babysitting a child, then you might say, okay, whoa, this person's risk just went from, think about the thermometer, from maybe it wasn't so high, they were managed well, it's up there. So then you want to try to reduce that risk as much as you can, and that can be done in a variety of ways. Again, it can be done through treatment, it can be done through more supervision if they're already under parole. You can tighten things up, but that's kind of the way that you would want to be approaching treatment, is kind of, what's the risk that I'm seeing, and okay, what can I do to kind of pull that down? And the treatment does that. Now, okay, if you have somebody, I have this slide here just also for your reference. So one of the things that we might see where I work is an individual who starts to become more sexually focused, sexually preoccupied. And it's good to know, well, what is sexually preoccupied? And this is from Kinsey, and it still actually holds today, but this is the average frequency of orgasm for individuals, and it could be alone or with somebody else. But if you have, say, a 20-year-old who is, and when you talk to them about, well, you know, what are your sexual habits, and what do you do, what do you think of when you're masturbating, those types of things, if that's something that you would end up doing, you might end up, if you have a 20-year-old who's says 15 times a week, and you can imagine people may also underestimate if they're kind of feeling embarrassed. This might be a person who is hyper aroused at this time, and then you would want to add either treatment or some type of supervision, but they need some sort of support or intervention. So I thought this was a good slide to also include, just to have, so we have normative, like what is normal. This seems to be average, adults. This is their arousal or frequency of orgasm. Let me see the time. Oh boy. Okay. And then another thing to think about, and I'm just highlighting this here just so that you have a reference. You also want to look at the level of psychopathy that an individual might present. And I'm not going to necessarily go into the details of psychopathy, but it's something that if you have access to a report, and I'll go to the numbers. There's basically two larger factors. There's kind of what we think about when we think about someone who's high on psychopathy. So it's somebody who someone who's very high might engage in criminal behavior, but may not necessarily feel the same remorse. They might be, if you're interacting with them, they might be kind of always have an answer for everything. Actually, let me give you an example for me. When I was doing assessment, one of the things that I guess you can call it the back in the office phenomenon. If I was evaluating somebody and their history was significant, and I found myself when I was interviewing with them going, yeah, boy, that makes sense. He shouldn't be here. No. And I found myself kind of maybe agreeing maybe too wholeheartedly when I was meeting with the individual and thinking, oh, well, that's a very plausible explanation. And thinking, oh, geez, I don't know if this guy belongs here. And when I would give myself about an hour later, I'd go back and I'd review the history and go, oh my gosh, what was I thinking? This individual was is clearly very high risk. Those individuals more often than not had very high psychopathy scores. So these are individuals who can kind of maybe have a good story, sometimes be quite believable, but always have an answer for things, but then also engage in antisocial behavior. So if you have somebody, and these are the kind of the numbers, if you're thinking about the numbers of risk, it's not a risk assessment instrument in itself. It can help inform risk, but it does help you understand whether someone's how they're going to make efforts in treatment and long-term treatment of efficacy. And so if you have an individual who scores 30 or higher, they would be considered to have psychopathy. If you have somebody when it starts to get into the 25 and above, that's somebody where you might kind of like check the story a little bit more, So these are things to think about if you encounter an individual and you have a report where you have access to the PCLR. And we don't always just look at the risk, the negative risk. We also need to look at protective factors. And I'm not going to necessarily go into detail so much about these, but these are things that also help lower risk. So if you have a supportive family member, if you have, if you think about when you want to eat healthily, if you have these kind of positive goals, and you're going to be more likely to do that, right? So individuals who offend, if they have these protective factors, and here are some of the things that are helpful. And you might also notice that these are things for anybody to live well and to live a good life. But if somebody who's offending, if they have a healthy sexual interest, it's not just focused on one type of behavior or a behavior that's problematic for other people. If you're able to, they can have intimate relationships, they can have positive relationships, they problem solve well. Those are all things that people who have those are less likely to offend. And there are things that you can do in treatment to help them to learn to do these things. It's not, we're not all born knowing how to problem solve well necessarily, or we might think about the trauma that people have experienced. That's going to make it so that it's harder for them sometimes their frontal lobes may be damaged, right? Because you have this early trauma, you don't think so well, and you might react more. So as a therapist, you can help a person develop these things, and that will help reduce risk to offending, and it will also improve their ability to desist, to keep from offending again. And I'm just going to highlight that this instrument exists, so if you're interested in looking into it, there's the SAPROF SO, and some of you I know in the hospitals they use the SAPROF, but there's a separate a sex offender version as well. And we don't want to just avoid bad things. We also want to make sure that we add things that are positive and protective for individuals, and that will help them to live better lives and avoid offending. So we went through the risk. So all of those can come into a risk assessment, and then we go to the needs. So what do we treat? Do we provide therapy? Do we provide correctional intervention? Do we provide community supervision? And you want to focus on things that are criminogenic needs. Now, if you remember what I talked about from the stable, that's the dynamic risk instrument. You'll see that there's a lot of overlap. If you have an individual who is struggling with their sexual preoccupation, you would focus on that. You would focus on, if the example also here is offense supportive attitudes. If somebody feels that it's okay to offend against children because I'm teaching them, that would be something that you would be working with them in treatment and considering learning to challenge those thoughts. And these are some other criminogenic needs. And research has found that when we focus on the things that address criminogenic needs, that those programs who do that are the most effective. We can help individuals with their impulsiveness, thinking through. The example before of an individual who said, when I stop and I think when I've got a temper, or I feel like I'm going to lose my temper, that is learning to manage impulsiveness, right? So these are all things that you can do and consider if you're working with somebody who's offended to protect them and help them to learn to engage in treatment. You also, in addition to treatment, individuals in New Jersey have parole supervision, and some individuals have parole supervision. So if you committed your offense, there's community supervision for life. So if you committed an offense before 1994, so you might look at when an individual might have offended, or you would have this parole supervision. It's pretty much the same. Parole supervision for life and community supervision for life are pretty much the same, but it started with community supervision for life. And in that case, if somebody who has done something that's problematic, or they're going, parole supervision for life is the more recent change to this. And the difference is that it actually gives parole the control that if somebody violates the conditions that are given to them, they can have them incarcerated for 18 months. So it kind of gave more control to parole in that respect. My understanding with CSL is that there's been more, you had to find a judge, it was a little bit slower, it was a little clunkier, and that parole supervision for life is what's been used now. But the reason I'm highlighting this is that if you have an individual who's offended and they have certain charges, they could have parole or community supervision for life, and you could know based on when they were charged. So I highlighted a couple of things here in red. So these are all this is a lot of what can come with it. So the parole can decide whether you can live a certain place, your job, those types of things. But individuals can get counseling if they have parole supervision for life. but it's at the discretion of the parole officer. So if you find you're working with somebody and they're looking like they're starting to rev up, if you think about that acute, where, okay, this guy he's hanging out with kids and he's doing things that are risky, you can talk to the parole officer and they can provide treatment for them in the community. So the other thing that I wanted to highlight with this as well is they're not supposed to be around, they're not supposed to have unsupervised contact with minors. So, and what does that mean? We keep emphasizing this with our residents who are discharged. This is an awake guardian with eyes on. So it needs to be a mom, a dad, whoever. This person needs to be guardian. It can't just be, I was with another adult and the kid was here. You need to make sure that if they were around a child and maybe they have a history of offending against children, that the person that they were with was awake and had their eyes on. They weren't, the parent wasn't outside and the individual who's offended is inside alone with the kid. That's what needs to happen, and that's important. Sometimes things, it's just something to consider if an individual crosses your path and you're feeling like, oh, I don't know if they really should have been doing that. That's really, if they're not under this condition, then that would be a violation. And some of them also have GPS, which is a tracker that goes on their leg, which it's a passive tracker, but there's a whole electronic monitoring unit from parole that would be, you don't have somebody necessarily sitting watching it, but you can have parole can look if there's concerning behavior that a person was engaging in. You can ask for trails and things like that and find out where they were at different times. So that's what the GPS provides. So this is some of the protective, therapy is wonderful, but you also have some more containment approaches with parole as well. And I just wanted to highlight, you can also have people who are on Megan's Law. And I don't necessarily want to go into detail, but sometimes I just want to differentiate. Parole supervision for life is where you have parole involved. Megan's Law is more about reporting. And the higher your tier, the more notification that happens to the community. And if you're tier 3, you actually would also have a GPS as well if it was after 2007. And that's also based on risk. So these are the different interventions. Oh gosh, I'm not gonna get to treatment.
There's a question.
Yeah, okay, go ahead.
Does the Riley decision only to offenders against minors? Does that apply only to offenders against minors?
I don't think so. I'm not 100% sure. I have not heard if it's only for individuals who've sexually offended. And I don't think it differentiates. I've never heard that, but I can check.
Okay, thank you.
Sure. Okay. The other thing is that, as we can work therapeutically with people, but you can also provide community support as well. There's what's called the circles of support and accountability, and here's the link here. And we don't officially have this in New Jersey, but programs can create almost their own. And what this is where you can have, in the Pura Costa, you would have volunteers in the community who are assigned to work with an individual, and they become their support system, because we know that when people have good supports, that's protective. So at the STU, while we don't have this COSA in New Jersey, we've kind of created our own. So when residents are leaving, we have them with a keep safe here. So that's an individual who's still at the STU. So they call back and they check with them regularly and talk about what's going on with them in the community. And they have a mentor in the community. So that's somebody who's already out there, can take them for pizza, take them for coffee, support them. Because a lot of times, at least when they leave, when someone's been incarcerated for a long time, it can feel a little bit lonely to leave. It can feel suddenly you're left with this unstructured life. And we also have a community resource team. So that's somebody that in the beginning they call more often. They call a professional here. They have parole, and they also have treatment in the community. And the idea is that all of these different providers communicate. So we'll find out sometimes if an individual is getting, their risk is going up, or they're going down, their behavior is becoming concerning. Sometimes we'll find out from the residents who are already in the community calling in or talking to us. And those conversations are very important. And a lot of times, ideally, we can just provide more support or kind of put some things into place that are protective so the person can stay out there. Sometimes it alerts us when, you know, we need somebody to return. But why I think this is important is, I think sometimes there's a thought that there's this kind of magic difference that sex offender therapy is, and a lot of it is the more protective factors that you put in for anybody. So if you have an individual going into the community from a psych hospital, if the more time you spend on discharge planning and community resources and those types of things, the more successful there are likely to be. So let's see.
So
And
in
I've got
one more quick question.
Yeah.
And I know we're getting really close.
Yeah.
But there was a question about, is there a tier 3 for offenders against adults? I'm sorry.
Yeah, it would be any, whether you've offended against it, if you've committed a sex offense, period. Yes. Yeah. Yeah, there's not really a differentiation in parole. That's nothing that I've ever experienced. There might be, so for an individual who's offended against children, so for anybody who's offended, and say if they want to live with a child, their own child, whatever happens to be, you can get what's called the living with child evaluation. And so that's where a professional looks and to see whether that's appropriate for you. So for example, if you've offended against adults, but you want to live, you've come out, you want to live with your child who's young, but that's never been somebody that you would have offended against, then somebody would do an evaluation and identify whether that's appropriate. So that's kind of where the differentiation happens. And so we're going to end at 4. So is it, we've got 3 minutes, is that it? Yes, we do. I apologize. That would get us to the treatment aspect of I thought I had enough time.
So I do want to just remind people that the handouts are available in the training evaluation.
Absolutely.
So we have access to all of these slides that we did not get to, but I'll let Dr. Stanzione finish up the last few minutes, and then I'll post the training evaluation link.
Yeah, let me say, so if I had to say anything about these last couple of slides, so responsivity is you want to deliver, and many of you are mental health professionals, you want to deliver the best treatment in the way that you best can do that. And that's all responsivity means. And there's lots of different ways that we do it. You want to have a good treatment toolkit, like any type of mental health treatment. It's nothing special. And treatment works. Most of the treatment that we do is group therapy. But you can do individual as well. And these are the different approaches. I was going to focus on the first 4, but CBT has the most research support, and it's a lot of the same ideas of any good CBT, helping people to model, do homework, role play, those types of things are used within treatment. Relapse prevention is more trying to understand how to avoid what you did. So we have the ideas that there's these cycles that people engage in, and some people engage in a cycle of reoffending, and you kind of learn and try to intervene at the different points in the cycle. We also have trauma. Let me go back. Okay. Oh boy, sorry. Okay. 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 So I highlight trauma-informed care because, as I said before, individuals who have sexually offended, and again, I highlighted early on, but I think it's important. People who are SVP or found SVP, the average is 4.85 for the ACEs. So, the more ACEs you have, the worse the more challenging things are for you. And it just keeps kind of, as the risk goes up, it seems to go up. And that's in contrast with just the general population, where about 13% of people have an ACE score of 4 or more. So you want to be considerate in the treatment. I know treatment historically for sexual offending, even when I first started here, the thought was, all right, you need to be confrontational because these guys are really different. And what the field, and this is where it brings me back to my counseling psychology degree, really the same things that help just general people do well are the same things that would help offenders. And when we kind of, if you're trying to like change a habit and someone's like gnawing at you, being like, don't do that, you're going to eat that, doesn't help you, right? So there's these more focus on strength-based treatment. And that comes from Good Lives is a good example of that. And if we have a moment, I can kind of just show that to you. And just trauma-informed care is also very important. So knowing that the justice system can be traumatizing. Right now we have a lot of substance abuse where we are, and the residents are struggling with, when we do drug tests, they're being observed, and that's kind of part of it. But that's, let's acknowledge that can be traumatic for people. I'm just going to highlight, because I think it's maybe helpful as well, just to kind of show what it is. So there's more focus on strength-based approaches, and Good Lives is one that is a strength-based approach. And a lot of those same things that I said before were protective factors. If you remember, go back to the SAPROF. Those are things that are part of the therapy of Good Lives. So the idea is that you work together, you work in any type of treatment, you work collaboratively, and you can develop a good life plan. But you, rather than focusing on, and actually all of these things are tools, they're all wonderful ways to avoid reoffending. So it's good to know, if you're thinking from an RP perspective, a relapse prevention perspective, well, let me stay away from that. Let me stay away from those bad things. Let me stay away from that bad food, whatever it happens to be, right? But you also know when you add things where I'm going to stay away from the bacon, but I'm going to add more things that I really like that are healthy, like apples or something like that. You do better. We do better when we have a balance and more of those approach goals. And that's the same thing for offenders as well. It's focused more on what can we help this person move toward. And it actually, there's it goes through these goods and these things that are important to all of us. And, we all want to have a good sense of relationships and work and a healthy, spirituality, and all of those things are really important to us. And with this, you would help the individual identify what's important to them, because what's important to you isn't going to be the same thing that's important to me, and look at how to balance those things. So one thought is that individuals who offend, you might be doing that because you're seeking to connect with people, but you're doing it in a way that's not helpful. So let's see if you can learn to relate to somebody, but in a way that is healthy and it doesn't hurt people. So that's a little bit of the Good Lives. So if you have a chance, you can look at all of that. So thank you so much.
All right, we're going to have to stop there. I'm so sorry. There's so much more to go. And I see some comments in the chat that maybe you should come back and do a part 2.
Okay.
But we do want to be respectful of everyone.
Yes, absolutely.
So thank you all for coming, and please follow the link that I posted for the training evaluation to access the handouts, the certificate, some more links, the video, and some other resources. And if you don't get a chance to do it today, we can send it out in the morning. Someone said agree to part 2. Okay. But thank you everyone for coming, and we will see you next month. Thanks so much.